The next session has been sponsored by Roche Diagnostics, so I'd like to thank them for that. We've got two speakers, Matt Fay, who's a GP in Shipley, a GP with a special interest in cardiology, and he's a CCG board member from Bradford District CCG, and Ameet Bakhai, who's a consultant cardiologist at Barnet with a long history of research experience in cardiology, and he's a consultant member of a CCG board. So I'll hand over to Ameet.
Thank you, Amanda. Good morning. Can everyone hear me? Great. Thank you very much for coming. First of all, I'd like to thank the organisers and also the sponsors, Roche, for inviting me, and that's the declaration of interest done. This is quite nice because not only have we got people in the room who are decision makers like myself, but most importantly, this is one of the most rewarding areas that you can attend, and it's about preventing strokes. Now, it's said that atrial fibrillation, an irregular heart rate that you can easily determine through feeling a pulse and then an ECG, is responsible for 12,000 additional strokes per year in this country. And the reason I'm going to start off with that number is that the cost of that is around 148 million when it was estimated about 8 years ago. And that's out of date. And probably the cost of those strokes today is around 250 million. Now, these may just simply be numbers, but when you equate that to the idea that you could employ an extra 6,000 nurses by preventing those strokes, or 3,000 GPs or consultants additionally in this country, then you start to see how important those numbers are. And as the last question from the audience was all about cost effectiveness, what is the short-term savings versus the long-term gain, that's in a really important area. And I'm pleased to be able to say not only am I a cardiologist, but I'm also an expert in clinical trials and health economics. And so it's with pleasure that I invite you to this talk. So that's me. I work at Barnet and Chase Farm NHS Trust, and there's a whole bunch of roles, and I have a number of declarations of interest. First of all, most importantly, is that I work in the NHS. Now, that's an immediate conflict of area because we have a fixed budget. We're not always allowed to do what we think is absolutely the best. We have to have decisions, discussions, and understand the rationing and the risk stratification with which we employ that. So that's an immediate conflict of interest, which no one ever declares, but I declare it. Okay, so we're here to discuss the burden of atrial fibrillation, the irregular heart rhythm, which is now an epidemic in this country, what it means, where are the gaps in the management of that, and how we can change that. What is the offering for that? And the first thing to realize is that, let's move on, we've discussed that one, is that our own chances from the age of 50 onwards of getting atrial fibrillation is 1 in 4. So your lifetime risk of developing this irregularity is 1 in 4. And as you can see from the prevalence chart, the amount of prevalence doubles with each decade, so that we're looking at about 9% in the over 80-year-olds. So if you want to find atrial fibrillation, look on the care of the elderly wards, look on the orthopedic wards, look in the nursing homes. That's where you'll find these strokes waiting to happen. And of course, the FAST campaign is very important, and that's our measure to say, can we get the patient who's about to have a stroke, is evolving into a stroke, into a thrombolysis unit within 2 hours to get their scan, and then get clot-busting drugs within the next 2 hours, so we can prevent the disability of that stroke, which is going to cost us over £12,500 just in that first few days alone. What about the patients who are admitted currently with stroke who are already known to be in atrial fibrillation? Well, in this slide, if you look at number 7 o'clock in the clock face, you'll see that only 10% of people are on the right medication, warfarin, in the right range. The other 90% of people, even though we knew they had atrial fibrillation, we did nothing correctly. We gave them the wrong medication, the wrong dose, or no medication at all to prevent their stroke, and lo and behold, they had a stroke. So we have problems, even though we know what the right thing to do in preventing strokes and atrial fibrillation, we have problems delivering those therapies. Let's go into that a little bit further. For over 30 years, we've known that warfarin is a good deal for patients in atrial fibrillation. And in fact, some of the SPAF trials, over 20 years old now, tell us that you can reduce the risk of stroke by 65%. That's a massive number, the relative risk reduction. If you look at any of the new therapies that you will be commissioning, they will have 20 and 30% relative risk reductions. Warfarin, compared to no warfarin, has a 65% risk reduction. Aspirin, on the other hand, is meager and has a 19% risk reduction, which is really very trivial, and it is a poor therapy to be on to prevent strokes. But what's the problem with warfarin? Warfarin has to be monitored and measured to get the right level of blood thinning. The international normocytic ratio has to be, normalized ratio has to be exactly right, between 2 and 5, otherwise you'll create bleeds or you won't be preventing the strokes. And it's difficult to monitor warfarin time in, time out at a GP practice or a hospital setting or an anticoagulation clinic. How important is it, and how well do we do? Well, in fact, in a number of national registries, we find that the best that the country can achieve in the average patient is that we get the warfarin right in the right level of blood thinning about 55% of the time. And that 55% equates to that orange line, which is very suboptimal compared to the red line. Getting patients in the right range for warfarin the right amount of time really prevents not only strokes, but also deaths, because there are fatal strokes also included in there. So there's a big difference from what we know we want to achieve versus what we are achieving. There are some ways of getting solutions to that, and one of the solutions will be to place people into a clinical trial. Here is a recent clinical trial called the RELY study, looking at dabigatran, and you can see the sixth column towards the right-hand side of the screen has UK on it. And we achieved, the fifth column, and we achieved 72% of the time in a clinical trial to get warfarin right. But those are younger, fitter patients with less comorbidities in a better setting where you're monitoring the warfarin literally every few weeks to get it right. Now, the trial was done to look at some of these new novel oral anticoagulants, clot-busting drugs that do not require monitoring. And of course, as you might imagine, they've been designed in the last 3 years, trialed and out there, and actually been proven to be effective. They are, of course, expensive. They are in the order of between £500 and £600 a year to prescribe, but they do not require blood testing. Does it matter that we have drugs like that rather than the old-fashioned drugs like aspirin and clopidogrel, which are weaker agents? Well, if you look on the right-hand side, getting an oral anticoagulation in the right range halves your risk of stroke and death compared to aspirin and clopidogrel, treatments that are sub-therapeutic. But if we look at some of the newer treatments, yes, you can see that the novel oral anticoagulants, expensive though they may be, in clinical trials have beaten warfarin in terms of preventing strokes. So they are better at preventing strokes on the whole. But what if we dig deeper into that study and look at the health economics? In this chart, you will see the comparison not only of the survival difference, but also of the cost differential between the novel oral anticoagulants and warfarin if you get warfarin in the right range. And if you look at the bottom right-hand chart, where you get the warfarin in the right range more than 70% of the time, novel treatments, as expensive as they may be, may not be cost-effective. Warfarin still holds its ground, but where you cannot achieve good warfarin INR ranges, then these novel agents are very cost-effective. So you've got a choice. Improve your standards or step up to new techniques, but it's going to cost you either way. Are there solutions to that? On average, it's estimated by NICE that we cost around £383 per year to monitor warfarin, and for that, on average, we get between 7 and 12 monitoring visits. So that's the annual cost. Are there ways to improve on that and tackle that? Yes, there are. There are a number of ways that we can look at as patients and physicians, and those are patient education, and patient education. But the minute you do that, you open it up to patient choice. And amongst the patient choice that we're not delivering today is enabling the patient to monitor their own warfarin levels, and that's a particular innovation that I'm very keen on. If I needed to be on warfarin, I would not leave it in the hands of a hospital setting to monitor my warfarin when I could do it myself rather than wait 3 hours in a queue. And I tell you, it's amazing. In England, in Barnet, at 9 o'clock in the morning, in our hospital, there is an outpatient store that does not open till 9:01. And you get 70 patients waiting in a queue that goes all the way out to the hospital entrance, and not one of them are talking. For the 1 hour that they end up waiting, they don't say a word. You go to the same queue in Spain with 6 people, and you'll have a party. And that's fascinating. I was like, hang on, you're here to meet each other every single month, and you never say anything. They just nod, and they just grin, and they just smile, but they never talk. It's amazing. I could sit there and do a comedy act, and it would be fantastic, I tell you. I get a whole bunch of laughs, not like you lot. You lot are dry as... No, I'm joking. Anyway, let's get back to the day job. So there are ways to improve the situation, and I think a focus on patient choice and empowering the patient, no decision about me without me, in the NSF outcomes framework is something I'm really passionate about. There are 5 domains, and I love these domains because understanding that you can tell somebody they've got a disease, recover them, and then rehabilitate them and give them a positive experience means that they will be repeat customers, not through design but through choice. And that's why I love what we do, because patients like coming to Barnet. They've got the Royal Free down the road, they've got UCL in the heart, they prefer Barnet. Some of them tell me it's because of the parking, but the rest of them tell me it's actually because of the doctors and nurses. So I'm inclined to think it probably is. But there you go. It's quite important to empower the patient. These are not token words. There are a whole bunch of people that are happy to manage their own warfarin. And perhaps one strategy would be to say, if in the traditional model you're not achieving good INRs, if you're in this mediocre range where we can't seem to get it right, you miss your appointments, you have dietary needs, you take your warfarin at different times, you're taking other spinach and alcohol and all sorts of things like that interact, maybe you might be people that we can either educate to enable you to do your own monitoring, or we can consider you for other strategies such as new drugs or even devices. Here are examples of new monitoring, and in the last 13 years, this technology has come a long way. We've now got robust technology that's portable, it's accessible, it's affordable, and it's actually validated against the hospital systems. And fortunately, on this occasion, we're talking with Roche, which is a very robust system from their INR monitorings. It's one of the ones that we use in our hospital, and so I recommend that without hesitation. And looking at those sorts of technologies, what does it really allow you to do? Let's move on to this slide. This is what it allows you to do. It allows people to monitor their own INR more frequently. And if you can achieve 7-day intervals between the last test, then you can get your INR in the range correct between 70 and 80% of the time. We can't do that in hospital. We give between 7 and 12 appointments at most because that's what's contracted. To see you more often than that is a massive headache. And so there are a number of patients, at least 15% of patients, we cannot get into the right therapeutic range most of the time, and this is one option. Does it matter? Yes, the blue line says that if you're allowed your own monitoring, this is 8,500 patients in the US, you have a better survival, and if you look at the differential in time in therapeutic range, it's outstanding. So that's yet one aspect of how to improve and enable patients. Another aspect is, well, how do we get access to these technologies or devices, etc.? And that is through improving the current existing anticoagulation clinic. And for this, we've done a massive exercise in the last 12 months and actually published quality standards to improve how an anticoagulation clinic should actually be performing. And this is important because this didn't exist. For the last 10 years, there have been no quality standards for how to improve time in therapeutic range, which is the outcome of an anticoagulation clinic. The metrics have been how quickly can you see the patient, how often are you seeing the patient, and what is your monitoring of the patient, but not about are there other strategies that you can provide, including patient education, patient empowerment, patient tools, online tools, etc., to improve time in therapeutic ratio, the main outcome that the patient wants to know. And so we've gone away and done consensus work, getting a whole bunch of experts around, 12 experts around a table to say what are the areas in which time in therapeutic range could be improved by, and how do we actually then take these questions out to anticoagulation clinics and see if they, the people who are running them, actually agree with these standards. And so we did a particular exercise where we had over 40 questions, and we got a very high agreement from the practitioners running the clinics as to whether they believe these are good quality measures. And in fact, some of those standards got 100% agreement out of over 100 people invited to comment on these questionnaires, say, do you agree with this statement? Do you agree with this statement? And so rather than spend a lot of time on these slides are available. What I want to tell you is to go and do this. Go pick up a copy of the prescriber, which is available on the Roche stand, to say what are these standards by which my anticoagulation service could be measured and the patients get a better deal. Because if you don't, we're actually wasting a whole load of money that could employ another 3,000 people like me per year. And you may not want to employ me per year, and you might think, these troublemakers, what the hell do they know? They're expensive, they put in fancy devices, they save people from death and heart failure and heart attacks. You might not want me. Maybe you can't afford me. But actually, when you have atrial fibrillation, or when you're at the risk of having a stroke, that's the time you'll think, no, hang on, there's a lot we could have done here to not only avoid this, but to have a better safety net for those patients at risk of stroke when detected to have atrial fibrillation, which amongst you are 1 in 4 chance of getting in the next 10 to 20 years. Thank you very much.
See how you go with time. You are very bad. You've taken all my
Hi, I'm Matthew Fay. I'm a GP and then a commissioner up in Bradford. I'm going to jump through a few slides. I just thought it'd be quite interesting to think that since this conference opened, somebody has had a stroke in AF that we knew was in AF and we didn't protect. And they are now going to cost us at least £12,000 to £20,000 in hospital care before costing us £50,000 a year in residential care. So we really do need to get into this. Now, a lot of people have been thinking that warfarin's dead now. We don't need to think about warfarin. We have these new super-duper drugs. They protect us against stroke. They don't require monitoring. Surely the game is over for warfarin. Now, NICE has given these drugs technical appraisals to say that they are good drugs, they are cost-effective. Didn't say we could afford them. It just said that they were good drugs and they are cost-effective. However, the majority of patients who are protected against stroke in AF in this country are taking warfarin. And while we are commissioning those services, we have to consider the quality of the service we commission. So when we look at warfarin, we have to think about control. And that control is assessed through the INR test, and the level of INR control is assessed through the time in therapeutic range. Now, the time in therapeutic range is a very important tool for us as commissioners to look at the quality of our clinics. It's not a particularly sensitive tool to look at how an individual is being cared for. What we looked at in our article, in our consensus, was to try and find, is there a way we can use TTR, time in therapeutic range, constructively? And the answer to that was yes, we can use it to assess our clinics. So we need to know how to do that. We need to get our clinics to actually report the time in therapeutic range, and we need to make sure that they are driving that therapeutic range as high as possible. Now, what that means for us in real terms is that when we think about a patient with AF, we have to protect them first and foremost. And any of you who are commissioning doctors to use aspirin in atrial fibrillation are wasting your money. You do not want to have that at all. It's of no value to prevent stroke in AF. May seem cheap, but it doesn't give you any outcomes. Warfarin is first-line therapy, very cost-effective. Only if we achieve good time in therapeutic range. If we do, then we have got an excellent therapy and we should be using it as much as possible. What happens if we don't? Well, we need to think about alternative ways to get the patient engaged. Near patient testing, patient self-testing and self-monitoring, and also then we have the option of a novel anticoagulant drug. This is a combined attempt to try and reduce the risk of stroke in atrial fibrillation. We have not got a one-size-fits-all. We have a variety of options, and patients should be given choice. Now, we're often told that the problem with our warfarin clinics is that they don't keep people in therapeutic range. Now, this is some data from INR-STAR, the most popular anticoagulation software used in primary care, and what we find is that is actually untrue, and that warfarin being monitored in primary care is highly effective, and the majority of patients, the overwhelming majority of patients, are actually in therapeutic range. So before we put warfarin in the bin and assign it to history, we have to think, are we actually putting away something which is highly effective and very useful and working well in this country? As Ameet has already shown you, of the people admitted with stroke in AF, only 8% had a stroke when their warfarin was well controlled. That means the majority didn't have a stroke that day. We got together a few people to have a chat about this, and we really can say we had the leaders in anticoagulation sat in a room. And we came up with ideas of how we as commissioners should look at our warfarin services. And time in therapeutic range became very important. We have high level of consensus across the people we asked. And all of them were saying, we've got to look at this as an indicator. We have to use it to compare our clinics. And we have to use it to see how people should be moved from the highly effective therapy of warfarin onto alternatives. The big risk with warfarin outside therapeutic range is we don't protect against stroke, and we also run the risk of increased bleeding. So how can we find this population? At least 5,000 people in this country will have a stroke because of AF each year because we've not protected them. There are nearly 1 million people in this country with AF. How can we find them? The GRASP tool, free from the NHS, will help you find in your clinical systems who has AF and what they're being treated with. Our problem with GRASP is it hasn't been an audit tool, it's been a counting tool. It's told us who isn't treated properly, but it hasn't made change. It hasn't got rid of the aspirin that we're paying for no effect. It shows us how the profile looks across our patients, but when we re-audit, when we go back to practices who have used GRASP, we find that we haven't got the dramatic improvement in anticoagulation we'd like to see. So what did we do in Bradford? We did it slightly differently. We decided to drive practices very hard with support, with no extra funding, to try and get them to improve the level of anticoagulation of their AF patients. And what did we achieve? We achieved what we set out to do. We managed to get the GPs to move from a prevention of prevention to an acceptance that we have to prevent AF-related stroke. Some practices did better than others. I'd like to point out mine did very well. But some of the change was incredibly dramatic. If we look at some of those pinnacles to troughs, we managed to persuade doctors that this was a way forward and protecting patients against AF-related stroke was worthwhile. And once we put all those patients onto warfarin, what did we do? Did we change the quality of our control? No, we made no difference to the quality of our control. We have excellent control in Bradford. Why? Because we commission services appropriately on TTR. What we can also say in Bradford is that if you actually compare what we did actively with our practices against QOF, we achieved a dramatic difference, probably about 20% difference, and that's even better if you consider that we actually improved identification as well. What was key? Well, we know that people have increased risk of stroke with increasing CHAD score, their stroke risk score, and we also know that those with the most to gain tend not to be the patients that we anticoagulate. However, in Bradford, and this is the first time this has been shown, we managed to actually improve anticoagulation of those patients most at risk of AF-related stroke, who had most to gain and were most cost-effectively intervened on. So, to try and sum up what we're saying, AF is a big issue for us commissioners. There are strokes occurring every 2 hours that could have been prevented with appropriate intervention. That intervention is anticoagulation and not aspirin, and we should incentivise the system to get aspirin out of AF care. The most cost-effective treatment to reduce AF-related stroke is warfarin and well-controlled warfarin. And now we have options which aren't warfarin for those patients who can't take or tolerate that therapy. Thank you very much.
Thanks very much to Ameet and Matt. I think it's very, very clear the sort of services we should be commissioning for our patients in AF. We've run over time, so I'm afraid there isn't time for questions, but I'm sure Matt and Ameet are happy if you want to approach them directly at the end of the session if you've got any burning questions. We've now got about 20 minutes for people to grab a coffee and have a look at the exhibition. There are a series of regional networking events going on in the stand in the middle. The next one of those to happen is for the London region, and that's at 12 o'clock. People coming back in here, we've got Paul Bowman, the Chief Finance Officer for NHS England, in here at 12 o'clock. Thanks very much.